Did you know people experience an increased rate of bone loss in the perimenopausal period? Although it's a frustrating and confusing time, it's important for people living with a spinal cord injury who are transitioning through menopause to pay attention to their bone health. Hi, my name is Anita Kaiser, and this is episode 4 of the podcast series Menopause and SCI in a Hot Flash, where we will talk about osteoporosis and its effects on menopause. Joining me is my colleague Margaret Conquest and our guest, Dr. Kathy Craven, a senior scientist at Kite Research Institute, medical director of the Spinal Cord Rehab Program at Toronto Rehab, and a professor at the University of Toronto. Welcome to the show, Dr. Craven.
Thanks for the invitation to be here today, Anita.
So I'd like to start first by having you explain for our listeners what osteoporosis is and why it's such a concern.
Great question. Bone has many important functions in our body. It is a source of nutrients, produces blood cells, protects our inner organs, and probably most importantly, supports our movement. Osteoporosis in itself is not a problem. People do not experience pain or discomfort with declines in bone density and changes in their bone architecture. But when people experience fractures, this can result in significant morbidity. And for those with motor complete spinal cord injury, a 5-year increase in mortality. So osteoporosis is really a concern in terms of reducing fractures. And I think that everyone in the field needs to be in the business of fracture risk reduction.
So in light of those issues and with the risk of fracture, why is osteoporosis a concern specifically for people with a spinal cord injury who are perimenopausal or menopausal?
Great question, Anita. At the time of the onset of menopause or in the perimenopausal period, women will have an increased rates of bone resorption. Often after a motor complete spinal cord injury, women will lose 3% per month of a decline in their bone mineral density of the hip and knee region. That is what I would call spinal cord related bone loss that results in sublesional osteoporosis. And if you have your spinal cord injury as a young person, you would then have menopausal related bone loss added on to the spinal cord related bone loss and result in accelerated decline in bone mineral density and an increased risk of fragility fracture. The opposite is also true. Women may have had postmenopausal declines in bone mineral density, then had spinal cord injury and experienced spinal cord related bone loss. So it is important for women to understand when the spinal cord injury onset was, how it affected their bone health, and then to understand how there's accelerated resorption or breakdown of bone at the time just prior to menopause and following the onset of menopause.
So how would I know as a person with spinal cord injury who is also going through the menopausal transition, know if I have osteoporosis?
Well, I guess it's important to think about what are all the roles of estrogen in a woman's body. So estrogen regulates the menstrual cycle. So when you get and how long you have your period for. It also influences, estrogen helps the urinary tract, influences the health of the heart and blood vessels, the bones, skin, mucous membranes, and the pelvic floor. So one of the first things that women often report is they'll have an increase in the time period between periods, and then gradually the loss of menses or no longer having their period is one of the first things they notice. But often women will also report other things, changes in their hair, their nails, their skin. How you would know you would have osteoporosis is to actually have a bone mineral density test, looking at ideally the bone in your hip and knee regions, so distal femur, proximal tibia, and the distal 1/3 radius, which is bone density of the wrist. Most women with spinal cord injury have normal or above normal bone mineral density of the wrist due to, wheeling, weight bearing for transfers. And then usually associated with perimenopause or early menopause onset, you will see accelerated declines in bone density at the wrist.
So earlier you had mentioned that you may not have any outward symptoms of osteoporosis. But how about if I have a spinal cord injury and a fracture occurs? if I don't have sensation, how would I maybe know?
So I guess some of the things that people will commonly report is that they have some regional swelling or they notice malalignment of typically a long bone. So something like your thigh bone or your shin bone or perhaps a toe or forefoot. The most important thing that we want people to know is that you should go to the ER and have an x-ray. Just a simple x-ray can be used typically to diagnose the presence of fracture, but that regional redness or swelling could be other things. It could be a blood clot, it could be early sign or symptom of cellulitis, it could be some regional bruising, but we want to make sure that it's not a fracture, and that simply requires an x-ray.
So I know you've already just described like what osteoporosis is, how it's diagnosed, but what about risk factors? Like, are there things that put me at greater risk for having osteoporosis and experiencing a fracture?
Great question, Anita. I just tend to think about fracture risk factors as the ones that you can change and the things that you can't change. So examples of variables you can't change, women over the age of 52 who are typically menopausal. If you've had a spinal cord injury for more than 10 years, having motor complete spinal cord injury or paraplegia, these are risk factors that increase your risk of fracture. Or, of course, if you have a family history of fracture in a first-degree relative, or if you have a medical history of kidney failure, hyperparathyroidism, or hypercalciuria, these are things you can't change. But there are a number of things that you can, through diet and lifestyle change, and really modify your bone health over time. So we'd like people to reduce their alcohol intake. If you're inactive, you can start to participating in load-bearing activity. If you have a low dietary calcium intake, you can do some dietary modification to ensure you're getting 2 to 3 servings of calcium-rich food per day, as well as an adequate protein intake. You can have a simple blood test to check your 25-hydroxy-D serum level. And if it's low, you can take a vitamin D supplement to correct your vitamin D levels. If you have low bone mass and high fracture risk, there are a number of medications that you can take to augment bone mass and theoretically reduce fracture risk. And there's a number of medications that we know increase fracture risk: opioids, benzodiazepines, and anticonvulsants. And those are the ones, if you don't really need them and we can gradually work towards weaning you off, that's what you'd like to do in concert with your medical team to try to modify the things that you can change to reduce your risk. And then, of course, for those who have incomplete injury and who are standing, walking, and walking on uneven ground, there's an opportunity for people to participate in balance training and fall prevention strategies. And for those who have motor complete injuries, there's certainly the ability to upgrade your wheelchair skills to reduce your risk of falls. Ideally, you'd like to visit your healthcare provider once a year to review what is my fracture risk, what are my modifiable risk factors for fracture, and to have your bone mineral density measured to see if your interventions have been effective in maintaining your bone mass and reducing your fracture risk.
That is quite a list of risk factors to consider, as well as things that I have control over and don't have control over. I think you've already hinted at it, but for those of us that may already be living with low bone mass or osteoporosis, is there anything extra we need to be aware of? And are there treatment options available specifically for those people?
Okay, Margaret, you're asking me some tough questions, so I'll try to answer with some sort of general concepts for people to think about. But of course, you'd want to discuss the treatment options for you individually with your healthcare provider who has measured your bone mineral density and knows your fracture risk. For almost everyone, you'd like to try to optimize your dietary calcium intake. And usually we'd like you to do that through food and not through supplements, because that calcium in food is much more bioavailable to your body. And for those people who have a history of stones in their bladder, stones in their kidney, we would recommend 750 milligrams of calcium per day. But for those who don't have a history of stones, 1,000 milligrams of dietary calcium daily. And we'd like to make sure that everyone is taking vitamin D to maintain a 25 hydroxy serum level above 110 nanomoles per liter. There are medications called anti-resorptive therapies, which can help to maintain or increase your bone mass and reduce fracture risk. And there are a number of physical therapies that can help. So if you look at having your calcium, vitamin D, and participating in a passive standing program, 1 hour, 5 days a week. This can be an effective means of helping to maintain your bone density and prevent the bone loss that happens early after injury. Or if you have access to funding or specialized equipment, you can do FES or NMES exercises, where you have a visible contraction and against some resistance in response to specific electrical stimuli. And this needs to be done 3 to 5 days a week for at least 3 months to increase your bone mineral density.
It sounds like there's a lot of things, and that in consult with a doctor, we'd kind of figure out what's the best approach. And it's good. It's kind of a relief, actually, to hear that there's lots of different treatment options. How long then would I maybe need to be on treatment for, or what's typical?
Typically, if you're a postmenopausal woman with low bone density and high fracture risk, you would probably looking at anti-resorptive therapy for the balance of your lifetime with intermittent drug holidays. We have a number of drugs available. We have some that are oral medications that can be taken on a daily, weekly, or monthly basis. We have IV drugs that bypass the gut and can be administered once a year. And we also have drugs like denosumab or ramosumab, which are a twice a year or once a year subcutaneous injection under the skin. Or we have teriparatide, which is our only anabolic agent, which is delivered through a daily injection in the skin for a year. So for most people, you would like to take a drug on a regular basis for at least 12 to 18 months, and then have a bone mineral density test to measure the impact of the drug therapy or the rehab intervention or the combination of the two on your bone mineral density. As you're aging, if you can maintain your bone mass without developing a fracture, that's a great scenario. If you're a younger person, you're sometimes able to actually increase your bone mass 3 to 5% with perfect adherence and taking advantage of combination therapy. After a person's had sort of a high cumulative dose or cumulative exposure to some of the drug therapies, we sometimes suggest that patients take a drug holiday and allow their bone turnover to recover. And we'll sometimes measure their bone turnover before starting or stopping drug therapy.
Okay, so then you kind of have hinted at how I might know if a treatment's working. What would maybe some of the reasons be that I might need to consider an alternative?
I guess the biggest one is if you're experiencing side effects, that would be a reason to stop the drug, or if you felt that the risk of side effects was not acceptable to you. But the biggest ones would be if you had an interim 6 to 8% decline in bone mineral density despite being adherent to therapy, or you experienced a new fragility fracture while on therapy, that would be considered a treatment failure.
Thank you, Dr. Craven. That's a lot of information that you just packed in for our listeners. If you could leave our listeners with a key message, what would you want them to walk away with?
Remember your bone health, even if you're distracted by your other menopausal symptoms. Vasomotor symptoms and other symptoms of estrogen decline or loss can be very distracting for women, but try to stay focused on your bone health and be in the business of preventing fractures.
Thank you, Dr. Craven. So if you found today's talk interesting, check out our action planning tool on the website at www.scifragments.ca, and feel free to send us your feedback using the survey provided on the website. And if you'd like to learn more about osteoporosis and spinal cord injury, check out our podcast series, the Bare Bones Podcast, on our website at www.scifragments.ca. In the next episode, we'll talk about the effects of cardiometabolic disease on menopause.